preoperatively, it's called a missed carcinoma gallbladder. However, most of the cases of carcinoma gallbladder are advanced cases, obvious clinical cases. So the workup will include an ultrasonography, few blood investigations like liver function test, tumor markers including CA19-9. For staging, it will include a CCT chest, abdomen, and pelvis. And whenever we are not going for an upfront surgery or whenever it is in a metastatic setting, we have to go for an ultrasound or a CT guided biopsy. When the patient presents with an obstructive jaundice, an MRI with MRCP can be done, and a whole body PET scan is advised whenever there is a suspected case of a gallbladder, but it is not as of now in the current guidelines. So management guidelines. So first we'll talk of an unsuspected carcinoma gallbladder. That is the carcinoma gallbladder which was not suspected in preoperatively, but in the middle of the surgery, the gallbladder looks cancerous. So whenever it is unsuspected, a radical surgery is advised if the expertise is available and the facilities are available at the center. If it is not present, it is better to close and refer the patient to a center with expertise. However, biopsy for the confirmation of diagnosis is advised without perforating the gallbladder. So, in brief, talking about the guidelines, we say early carcinoma gallbladder, that is stage T1A. So, stage T1A, simple cholecystectomy is said to be curative because, and there's no revision surgery needed or lymphadenectomy as the metastasis is less than 5%, as lymph node metastasis is less than 5%. However, in stage T1B onwards, stage 2 and stage 3A, radical cholecystectomy followed by adjuvant chemotherapy plus minus radiotherapy if the margins are positive. And stage 3, 4, and 4B onwards, these are not tumors which can be taken up for upfront surgery. So perioperative chemotherapy followed by surgery if the, depending on highly selective cases, if the patient becomes operable after the pre-adjuvant chemotherapy. Now, talking about incidental gallbladder cancer. So, in cases of an incidental gallbladder cancer, the pathology has come out to be carcinoma gallbladder, but none of the preoperative workup was suspected of it. So now we have to do a complete metastatic workup, which will include a CT chest, abdomen, pelvis, or whenever the patient presents after 6 weeks, it is advised to do a PET CT because it will cause an upstaging in as high as 40% of patients. Or labs are to be repeated with tumor markers, including CA19-9. Histopathology should be reviewed entirely, and entire gallbladder has to be processed. The T stage has to be noted, cystic duct margin has to be noted, cystic node has to be noted, and then we have to proceed as staged. And if the patient presents after 4 weeks, it is advised to go for a diagnostic laparoscopy at can be done at the time we are taking the patient for surgery. And
I have one doubt.
yes.
What about this? All what you are saying
Yes.
is from NCCN guidelines.
No, it's from TMC guidelines.
Okay.
Yes. So, revision surgery. Revision surgery will stay same as the radical cholecystectomy, and we have to confirm negative margins of the cystic duct on frozen section. Extrahepatic bile duct excision can also be done to obtain negative margins if the nodes are densely adhered to bile duct. And however, routine bile duct excision is not recommended. Talking about the time at which revision surgery should be performed, it should be performed as early as feasible. There is no upper or lower limit of revision of time of surgery. So, a need of pre-op tissue diagnosis, as discussed, the pre-op tissue diagnosis is needed only when patient is inoperable initially or metastatic, or whenever we are planning to give a neoadjuvant chemotherapy first, or also whenever we are anticipating major resections, which can include extended right hepatectomy or hepatopancreatic duodenectomy. So, technical considerations. So, we will label the patient as unresectable whenever in carcinoma gallbladder there is a proper hepatic artery involvement or main portal vein involvement. However, it is resectable when the tumor is confined to gallbladder and there is a contiguous involvement of the liver or contiguous omentum involvement or stomach or colon involvement. The lymph nodes are confined to HDL, or whenever there is a lone duodenum, just a segment of duodenum involved, when we can do a sleeve or a segmental and can achieve an R0 resection. So, a surgical treatment which was proposed, the Glenn and Hayes proposed en bloc resection of the gallbladder along with the gallbladder fossa in the liver and the hepatoduodenal ligaments, lymph nodes. And further, Shirai et al. Has also said that can include CBD excision, and it can be described as an extended radical cholecystectomy, CBD excision, to make sure that the margins are negative. End stage, it was earlier location based. Now it is the lymph node based. N1 is 1 to 3 lymph nodes positive. N2 is 4 or more lymph nodes positive. And at least 6 lymph nodes are must for harvesting for a proper staging. So non-regional lymph nodes, involvement of celiac, SMA, and interautocaval lymph nodes make it a non-regional lymph node involvement, as the outcome of these lymph node involvement is said to be as bad as metastasis, even if an extended RPLND is performed. Now, talking about routine 16B lymph nodes, 16B1 lymph nodes. So, in whenever CT of abdomen is done, we can uh, evaluate 16B1 lymph nodes by whenever the size of lymph node is more than 10 millimeters, a rounded shape with heterogeneous architecture. And in various studies, the sensitivity and positive predictive value were very low. It was 14.7 and 33.3% only. And significant number of patients without these radiological characteristics were also found to have 16B1 lymph node metastatic involvement. And however, whenever the patient is potentially resectable, routine lymph node biopsy is not usually done preoperatively. However, then during the surgery, it is always advised to do a 16B1 lymph node biopsy before before the surgery, because if these come out to be positive, the patient has a bad outcome. And the yield of 16B lymph node positivity was also found to be higher when the patients had jaundice or a locally advanced gallbladder cancer, and preoperative serum tumor levels were higher. So, extended right cholecystectomy. So, extended right cholecystectomy in carcinoma gallbladder is said to be done in two scenarios. First, when the tumor of the gallbladder will involve the neck of the gallbladder, causing right portal pedicle involvement, or whenever there is a large tumor in the fundus or body of the gallbladder involving extensive involvement of the liver parenchyma. However, even when extended right cholecystectomy is done in these settings, it is associated with a very high associated mortality due to preoperative jaundice, biliary sepsis, and aggressive biology. No, yes, we consider it as an enough. Do you? I I I have heard in Rajiv Gandhi certain people do. Do you people also do a 16B positive, isolated 16B positive? Do you go for resections? Okay.
At our center, we after harvesting 16B, if it comes positive, we did not proceed.
We proceed only if the patient has symptoms of jaundice or something, when more of a palliative sort of resection. If the patient is symptomatic, and if she is a young age or the patient is of young age, if it may benefit the patient in some way, then we go ahead with surgery if it is resectable. Otherwise, we may go for neoadjuvant chemotherapy if initially on PET it was positive. Sometimes we do PET,
We do PET.
whichever patients we have seen, we have advised PET for them.
Hmm.
We don't go any. There are no any specific. There are no specific indications as such, but we straight away go
All
with PET in
supramajor
majority of
surgeries
the patients
we advise PET to rule out the metastatic work.
for metastatic workup.
Hmm. Hmm.
Depending on the patient to patient basis. Like if it will benefit the patient in some way, then we go ahead. Otherwise, we don't.
Physical condition, age, other
She is young age and
status.
it may provide some advantage. Like further, if in future she is going to obstruct, she may land up in biliary obstruction. Then we may proceed
All
with
right.
resection if it is still resectable. Otherwise, no.
But now I think there are a few studies which are also suggesting that if isolated intraoperative interautocaval lymph nodes are positive, I think this year or last year, I think Rajiv Gandhi, somebody in Rajiv Gandhi was doing this study that patient will does patients do have survival as good as a non lymph node positive group. So doing a radical cholecystectomy even in patients who've had only isolated 16B1 lymph node is also good enough. Few studies have come up with that also.
In our hospital gastro department, people will do this radical chole. In drop 16B1, they send for frozen section, and if it shows microscopic deposits, they go ahead with the surgery. If it shows some microscopic kind of thing, they abandon the surgery. They say that the prognosis with microscopic is as good as the normal one. 40 Shalimar Bagh.
Okay, all right. So next we're going to talk about hepatopancreaticoduodenectomy. So hepatopancreaticoduodenectomy is when we do a pancreaticoduodenectomy along with a major liver resection. That is not a 4B5 liver resection, but another major liver resection along with pancreaticoduodenectomy. The experience of this has been in a very, very few centers and with a very high mortality rate, with a 5-year survival out only 3 out of 38 patients and a median survival rate of less than 1 year. So there have been a lot of studies which have studied hepatopancreaticoduodenectomy for advanced gallbladder cancer, if it was worthwhile or not. So it has been said that in various studies, some say a median survival of 1 year to 2 year, and they said that hepatopancreaticoduodenectomy can be done in a very, very selected group of patients in advanced gallbladder, but but mostly the survival in these patients have not been very good, and it is done in a very, very low it's done in a very selected patient population and in a very expertise centers with a lot of expertise. And they said that the only indication which can include the reason for a hepatopancreaticoduodenectomy is when there is an extensive horizontal tumor spread with infiltration of hepatic ileum and intrapancreatic bile duct, and in these cases the reconstruction may also be required. And negative margin has to be created. But most of these studies have not really taken carcinoma gallbladder as such. They've taken intrahepatic cholangiocarcinomas, and the number of patients which were actually of carcinoma gallbladder have been very, very less in these studies. So actually, carcinoma gallbladder undergoing all of these resections have had a very poor prognosis. These data have been extrapolated from studies which have had major proportion of intrahepatic cholangiocarcinomas. So earlier, the adjuvant therapy, the indication of adjuvant therapy, which was said was any patient with an R1, R2 resection, or even with R0 resection with T3 node positive disease, PNI, LVI, pericapsular invasion, with patients with tumor budding, or even with patients with who had a bile spill during the index cholecystectomy in an incidental carcinoma gallbladder. And there have been no actually RCTs on adjuvant carcinoma, on adjuvant chemotherapy in carcinoma gallbladder, and most of these have been extrapolations from biliary tract cancers. But few trials which have been done, like Prodigy 12, which have experimented from Gemox and capecitabine. So now when they say that all right, so so there have been studies which have extrapolated data from biliary tract cancers to carcinoma gallbladders, which some of these are like Prodigy 12, Accord 18, Unicancer GI. This was a multi-center open label randomized phase 3 trial which included 196 patients, and they randomly assigned patients after R0 and R1 resection of localized biliary tract cancer to either receive Gemox or for surveillance. And they did not observe any kind of difference in recurrence-free survival between two arms. In another study, which BILCAP study, which randomized capecitabine compared with the observation in resected biliary tract cancer, they randomized adjuvant capecitabine, and they observed that capecitabine was associated with an improved modest toxicity, and quality of life was also comparable in both the arms. And after BILCAP study, authors have recommended using the capecitabine. So data has been very uh, hazy about it. Similarly, there was this another study, SWOG S0809, and they took R0, R1 resection patients of extrahepatic cholangiocarcinoma or CAGB after radical resections, which included stage T2 to T4 and positive with positive or resection margins. And they included patients with gemcitabine, capecitabine, and radiotherapy, and they looked at the survival. And median overall survival was 35%, was 35 months. And the combination was also tolerated with a lot of patients, and it had promising efficacy. And so now that they say, uh, I would want to share this one slide, just a second. So now they actually say that any patients with T1 and above gallbladder cancer should be subjected to adjuvant chemotherapy, and it is usually a gemcitabine and cisplatin based chemotherapy, which is usually taken in most of the cancer centers. And what is the chemotherapy protocol which is usually taken in your centers? In our center, it is usually gemcitabine cisplatin. Okay. Okay. So talking about palliation, so patients who are not fit for upfront resection, some palliative options. So these days, not most of more centers perform surgery for palliative purposes. Mostly palliation is done usually by intervention radiology. Palliation can be done by intervention radiology options. So palliation can be done for three reasons: either biliary obstruction, gastric outlet obstruction, or pain. And various non-surgical interventions which can be done to palliate are endoscopic, percutaneous, or a EUS-sided celiac block for pain. So, as we know that surgical resection is the only potential cure. So, neoadjuvant chemotherapy is now given in a lot of settings. It has a lot of benefits. First of all, to evaluate the biology of disease and identifying candidates who will actually benefit from surgery. Also, in downstaging treatment who are not upfront operable. So they take most of the patients who are more than T3A and take them for neoadjuvant T3A or node positive. They take for neoadjuvant chemotherapy. But a lot of studies also have said that patients who are upfront operable, giving neoadjuvant chemotherapy can help in evaluating the biology of disease, and patients who will actually do better after the surgery. So it will improve surgical outcomes, and not only in incidental carcinoma gallbladder, and also in it will improve surgical outcomes in not only locally advanced carcinoma gallbladder but also incidental gallbladders who after staging have come out to be locally advanced, or patients who've had any kind of I have a table which will include the TMH criteria for neoadjuvant chemotherapy. So they say that the high risk gallbladder cancer will include any T3 and above node positive gallbladder cancer, which has a high incident of micrometastatic disease with an early hematogenous lymphatic spread. And the ultimate determinant is actually selection of the favorable biology. And to initiate chemotherapy in these patients is whenever we identify any patient with a high risk carcinoma gallbladder, it is always helpful in initiating chemotherapy in these patients, because it will help in the natural selection of the patients, and it will help in R0 resection in these patients. And there is this paper from Tata which included NACT in patients with locally advanced carcinoma gallbladder, which had 37 patients with a 67% overall response rate, and 46% could undergo R0 resection with an overall survival of 13.4 months. And thus they included that NACT actually improves resectability in locally advanced carcinoma gallbladder cases. And just a second. So this is the table that I wanted to share with the Tata guidelines. So they have given various groups in this. The first one is the incidental gallbladder cancer. So any patient with an incidental gallbladder cancer who has, after staging, proper staging, have any kind of residual or recurrent mass in the gallbladder fossa or liver bed, or as per nodal criteria, they have just, can you see my screen? I'm sorry. Okay. Uh, just a second.
Yes, helpful, ma'am. It is giving a quick revision and approach.
Yes, yes, yes. Yeah, yeah, Rohini. No, it is helpful actually.
She didn't discuss the questions those that were asked in the exam, right? It would be helpful if she first enumerates the questions or whatever was asked in the
So there
past
were three
paper.
questions. One of them included incidental gallbladder cancer. The other one was cholangiocarcinoma and Klatskin tumor. I'll come to that.
Given the outline before the lecture, like what questions are we going to exactly going to discuss would be helpful. Otherwise, she is going very pretty well. But if she gives this outline, ki what we are going to do exactly, which questions exactly are we going to discuss, it would be helpful. Hmm. एग्जाम में क्या कैसे लिखना है वैसा किया तो आई थिंक
Hmm.
बेटर रहेगा कि इट वुड बी हेल्पफुल कि डायरेक्टली इसे रिवाइज करके वी कैन कवर अप जो भी है। यस यू आर राइट बट सबको इतना टाइम रहेगा नहीं रहेगा पता नहीं। तो जैसे however, जैसे भी हम लोग हेल्प कर सके जो भी प्रेजेंट कर रहा है वो टॉपिक इट वुड बी हेल्पफुल कि थोड़ा एग्जाम पॉइंट ऑफ व्यू से क्या तो सबका जल्दी हो जाएगा। आई मीन उसका भी प्रिपेयर होना है एंड बाकी लोगों का भी इट वुड बी हेल्पफुल।
I
Yes,
think we
right.
should make
Otherwise, she
a.
is going fine. She is presenting very well. सब बता रही है बट एग्जाम पॉइंट ऑफ व्यू से किया तो सबका टाइम बच जाएगा।
So I think what we should do is we should make a timetable, give people some time what topics they want
हाँ
to discuss.
नहीं अभी करेंगे अभी जो भी है करेंगे बट विल एटलीस्ट लेटर फिनिश वो बता रही है लाइक विल लेटर फिनिश फर्स्ट उतना चलेगा।
So let's just finish the thing up, whatever. So this is one important table that I wanted to share with all of you. I think this will help in whatever questions that we get for gallbladder cancer. So basically, the indications for neoadjuvant chemotherapy, this we should know. So incidental gallbladder cancers may any kind of when we restage the patient, any kind of residual or recurrent mass in gallbladder fossa or liver bed whenever it is found, or N1 disease as per nodal criteria, or whenever there is a bile duct involvement causing obstructive jaundice. So in those cases, in incidental gallbladder cancer, these patients are out. These patients are candidates for neoadjuvant chemotherapy. So other than that, vascular involvement, whenever there is a, as I told you, common hepatic artery involvement or portal vein involvement becomes unresectable. Then we have to give neoadjuvant chemotherapy. N1 may be whenever there is a any kind of N1 disease, hepatic artery involvement, HDL involvement, retropancreatic involvement. Agar we know preoperatively we know it is said that this is borderline resectable, give patient neoadjuvant chemotherapy. And even T3 T4 disease mein they say that contiguous liver involvement of more than 2 centimeters या फिर bile duct involvement causing obstructive jaundice या फिर radiological involvement है enteropyloric stomach duodenum hepatic flexure और colon और small intestine का, these all are labeled as borderline resectable by TMH, and they say that you should give neoadjuvant chemotherapy in these patients. So I'll just skip all of this. So, obstructive jaundice. Obstructive jaundice may first of all we have to rule out stone, and MRCP has to be done in any patient of CAGB with the obstructive jaundice because we have to rule out the stone disease. Also, we have to ascertain the exact level of block. Okay, so whenever there is a lower CBD block due to nodal compression, we have to do ERCP either with plastic or SEMS. And whenever there is a type 1 or type 2 communicating block with roof intact, we have to do either the plastic stent or short SEMS, or whenever there is a type 2 non-communicating type 3 or 4 block, then only PTBD or bilateral or unilateral SEMS can be done. Talking about the surgical aspect mein we do a standard radical cholecystectomy. Staging laparoscopy has to be done in every patient. Inter-aortic lymph node biopsy in every patient, and lymph node dissection will include HDL, retropancreatic, and common hepatic lymph node. 2 centimeter of liver wedge has to be taken with GB fossa, and lymph node dissection of HDL will include up to porta hepatis around common and proper hepatic arteries up to the right side of celiac axis and behind duodenum and pancreatic head also. Extent of liver resection will include wedge resection of GB fossa, 4B and 5. And as I told you, indication for extended right hepatectomy can also be done. And anatomical resection, there are various techniques which have been discussed regarding anatomical resection, like the IOUS technique, Miyazaki technique, in which we have to clamp the right posterior pedicle in the Rouvier sulcus and then go for the outlining of the segment which we have to resect, or we can ligate segment 5 pedicle, and then we can do an intraparenchymal or a Gleasonian resection. or we can do an ICG injection into cystic artery. So these are a few techniques of doing the resection. And these were the most of cases which we will get during the surgery. And I think I'll just share this PPT with you all, so it helps you whatever questions are there. The other questions that we'll get are cholangiocarcinoma. So that cholangiocarcinoma I'll share with you. So cholangiocarcinoma, the main classification is intrahepatic perihilar and distal cholangiocarcinoma. And tumor of intrahepatic cholangiocarcinoma will include only 15 to 20% of all primary liver malignancies also, and 20% of total cholangiocarcinoma patients also. And intrahepatic cholangiocarcinoma has various kind of growth patterns, including mass forming, periductal infiltrating, and mixed type. And mass forming intrahepatic cholangiocarcinoma shows a radial growth pattern invading the adjacent liver parenchyma. Lymph node stations, including intrahepatic cholangiocarcinoma. So the pattern of lymph nodes is basically lateral. So tumors in the left liver, whenever there is an intrahepatic cholangiocarcinoma on the left side of the liver, it preferentially drains to the inferior phrenic lymph nodes and lymph nodes along the lesser curvature of stomach, and subsequently the celiac lymph node basin. And right side of intrahepatic cholangiocarcinoma drains to right-sided hilar lymph nodes and subsequently to portocaval lymph nodes. So whenever we have to do a left liver intrahepatic cholangiocarcinoma, we have to dissect out phrenic, hilar, which will include CBD, hepatic artery, portal vein, and gastrohepatic lymph nodes. And right side, we have to do hilar, periduodenal, and peripancreatic lymph node basins. This was intrahepatic. Now talking about the perihepatic and the perihepatic cholangiocarcinoma. So we all know the Billroth-Colruyt classification of CBD tumors, biliary tract tumors. So the type 1 is tumor which is limited to the common hepatic duct below the level of confluence. Type 2 is involving the confluence. Type 3 is further divided into 3 and 3B. 3A involves type 2, that is involving the hilum and plus extension to the right side. Type 3B will include type 2 involvement plus extension to the left side, and type 4 will include both left and right. So perihilar cholangiocarcinoma is basically involving the main lobar extrahepatic ducts, and it is basically characterized by local and regional growth patterns, and PNI is typical for perihilar cholangiocarcinoma. And it can include it can grow intrahepatically or proximally with the involvement of lobar ducts. And cholangiocarcinoma may also extend radially with the involvement of hepatic parenchyma or with arterial or portal venous involvement. So perihilar cholangiocarcinoma, treatment of them for type 1 and type 2 lesions, we have to basically do a en bloc resection of extrahepatic bile duct and gallbladder with clear margins, with lymphadenectomy with a Roux-en-Y hepatococcygeostomy. Type 3 may involve a hepatic lobectomy. Also, in type 2 and type 3 lesions, they say that caudate lobe is mostly involved. So, many surgeons also recommend a routine caudate lobectomy in type 2 and type 3 tumors. And in type 3 and 4 tumors, which are amenable to curative resections, they usually also recommend doing hepatic resections. And adjuvant treatment, as discussed in carcinoma gallbladder, adjuvant chemotherapy with gemcitabine cisplatin is advised, and patients which have a margin positive tumor, in those patients radiotherapy is also recommended. So is anybody online?
Dr. Avneet, I just want to ask that how that injection in cystic artery, ICG injection is going to like any detail you know?
So there have been a lot of techniques which have been given. So some surgeons, they give an injection of so cystic artery is first dissected, and dye is injected into the cystic artery, and they do a wedge resection of the stained area alone. So they don't take the entire 2 centimeter margin. But then it also has a limitation because the venous draining areas can cause a lot of micrometastasis. So whenever they take a hepatic resection just based on cystic artery, they do not include the areas which may be involved by venous drainage areas. So this was a very debatable kind of a technique.
Okay.
Yeah. We've had just 2 or 3 perihyalarcal angiocarcinomas. Not a very good outcome, although both of them. No, 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 perihilar we've had 2 till now. By the time that we joined, we've just had 2, but the outcome wasn't very good in both of them. No, no, we just take a standard 2 centimeter technique only. These were all techniques that I went through, and I thought I'll just share with all of you so that, just in case if they ask. So they also do this Miyazaki technique in which they ligate branches of 4B. They wait for an appearing of a demarcation line, and on one side they will dissect on that demarcation line, the other side on the Rouvier circus, and then they will join these two and do the parenchymal transection.
I think we should proceed.
Ashley, we can just discuss. If she doesn't come, I think you can only present. We'll get over with 2 topics then.
Yeah, you can present, we will discuss.
So at least 2 topics will be over.
You can discuss and from like
Okay.
पर मी निघू का? मी निघतो म्हणलं.
so, I just want to give one suggestion. Isn't it good we discuss the papers from like most recent one to backward? Divide the questions, allot someone, and then they can present accordingly.
I think जो question है किसने share किया है ना, if we could go by that, it would be helpful for everybody.
Like can pick up one paper, you can divide the question.
Discuss करना चाहे तो it is limitless. वो जितना जो पढ़ेगा वैसा है, but अपना main targeted approach रखा तो it would be helpful. बाकी answers बनाने में अगर किसी का time नहीं जाएगा.
Exactly. Like if even we give one question to one person and 4 persons present in the end, it will be good enough.
जैसे क्वेश्चनर के हिसाब से गए तो अदरवाइज अभी क्लास के लेक्चर्स ही 2-2 घंटे रहते थे फॉर ईच टॉपिक दैट भी वो अपन वैसा नहीं कर सकते पूरा थियरी डिस्कस
Yes, this is a good idea. Good idea. We can share the questions among ourselves, and at least each candidate can do 2-3 questions.
Like we can
जो 10 marks का आंसर लिखना है वैसा we can prepare it. उसके साथ if we need to discuss something else also वो कर सकते हैं, but primary target वो रखा तो ज्यादा बेहतर रहेगा, ऐसा मुझे
तो
लगता है।
व्हाट वी कैन उसके अलावा भी ना एक कर सकते हैं, इफ वी आर डूइंग अ क्वेश्चन बेस्ड काइंड ऑफ थिंग। एक काम करते हैं, लेट्स जस्ट जो हमने टॉपिक डिसाइड कर रखे हैं, वो टॉपिक का जो जितने भी क्वेश्चन है, उन क्वेश्चंस को मतलब पीडीएफ फॉर्मेट में या एमएस वर्ड फॉर्मेट में उसके क्वेश्चन के आंसर्स बना के शेयर कर देते हैं, सो दैट
वो
एवरीबॉडी हैज अ नोट्स का वो तो होगा ना, कि कम से कम जब हम क्वेश्चंस डिस्कस करने लगेंगे हमारे पास वेल मेड नोट्स हैं।
ट्रू
हाँ,
ट्रू
वैसे
ट्रू।
हाँ,
वही
कर सकते
आंसर अभी डिस्कस भी किया है इधर, तो भी 2 बार रिवीजन हो जाएगा, मतलब ऐसा है।
तो एक
जैसे
काम करते हैं, लेट्स जस्ट ट्राई मेक नोट्स ऑल्सो। तो जैसे जीबी है, तो जीबी का एक, जैसे आई हैव मेड दिस, तो आई कैन शेयर द पीपीटी ऑल्सो, एंड मैं एक पीडीएफ बना दूंगी उन 3 क्वेश्चंस का, जो जीबी के अभी तक 3 क्वेश्चंस आए हैं उनका। आई
हाँ,
मेक अ
वो
पीडीएफ एंड आई शेयर। सिमिलरली जिनका हेड नेक का है, दे कैन मेक अ पीपीटी आल्सो एंड दे कैन शेयर एक पीडीएफ जिसमें वो सारे क्वेश्चंस और उनके आंसर्स बना के वी कैन शेयर, सो दैट सबके पास एक कॉर्पस होगा ना क्वेश्चन एंड आंसर्स का, कि बस उसको खोलो, पढ़ो और खत्म करो।
एग्जाम के लिए वही काम होगा, थियरी तो लिमिटलेस है, कितना भी करो।
हाँ, वो है। तो इसमें अपन ईयर वाइज कर सकते हैं और टॉपिक वाइज भी कर सकते हैं। आई थिंक ईयर वाइज विल बी बेटर सो दैट वी कैन डू द फ्रेश क्वेश्चंस फर्स्ट एंड देन फॉलो।
ठीक है, एवरीबॉडी इज एग्रीइंग विद इट, तो अपन वैसा करते हैं, एक बार नेक्स्ट टाइम एक बार ट्राई करके देखते हैं। हाँ but
सुरू झाली?
नहीं, वो रह के भी वी हैव टू
हाँ,
राइट सम आंसर इन द एग्जाम ना।
वी शुड बी एग्जाम स्पेसिफिक मोर मैम, आई थिंक
थोड़ा
सो।
सा एग्जाम ओरिएंटेड रखा तो। वो भी है, तो ना पीपीटी है वो, और जो लिखना है वो तो बताना। हाँ, वैसा क्वेश्चन रहेगा तो वैसा आंसर भी बनाना पड़ेगा। यस,
In
वो
that,
बात तो है।
problem is that general onco presenting stats and all these general topics will be missed out because no one is preparing presentation on such topics. Only अगर 10 लोग रहते हैं तो मंथ 2 क्वेश्चन आता है everyone, like 2 questions on month we can prepare easily.
This is the very initial days, na. Let us wait for some more days. People might join as classes go ahead.
Yeah.
Yes.
And some small There is critical thickening and filtration of the hilum, so it lost its shape, like it is
Fat, at hilum, fat gets infiltrated by the tumor cells,
yeah.
so that it becomes hypoechoic and a round cell. Sorry.
Yes, ma'am. It is mentioned now the
No,
phagocytosis
this is newer actually.
normal lymph node will uptake. If it is normal, they will uptake the nanoparticles and appear black on an activated mRNA. So if it is like having disease, it will not phagocytosis will not happen. Then it will not appear black. So that is what it mentioned.
No, we
We will
don't do any sentinel lymph node biopsy at our center. Or
Our
at any-
center also we don't do.
We did it once in a varicose, very small lesion, and on that lesion we gave ICG, at 3 and 9 o'clock. 0.1 centimeter. 0.1 ml. Just one.
Yes, sir.
Yes, yes. Yes.
Significant level 2A and 3 while doing 5. That it's shown in red colors. They are statistically significant. So these, if these nodes are positive, we should address like that. They want to say. It is for if they are positive, then we address 5. That's how
No,
it is.
they mean that in buccal mucosa and RMT, if level 2A and 3 are positive, then the probability of level 5 being positive is more there.
We should level
I
5
think
also.
so.
Yeah. Exactly. Hmm.
Yes, thank you.
No, I think it is different for elective neck dissection and for selective neck dissection. This I am not sure exactly which trial or which paper says that, but it is said that for MRND, the minimum number of neck nodes should be 15, and for selective neck dissection, the minimum number of lymph nodes should be 10. 15. For MRND, it is 15. It was there. This question was there even for NEET also, I guess. Yeah. Esophagus 15, stomach 16. For head and neck, I think it is different for MRND and MND, and for SND, it is different number of nodes.
I he's telling right. It is for END. I think 15 in the last slide. You can see last slide. It is written like last slide, just last slide, not last. Presentation, it was number slide.
Previous
Na?
to this.
44.
Previous to this. 40th slide.
Yeah. So it is written up. Removed in all 1 to 4 are likely better outcome. Yeah.
I feel what Rakesh and Dr. Rakesh and others were saying, they were telling about this targeted reading. No, I think that is much better for our exam because it is never ending.
It is so vast.
Presenting like this is never ending because every topic is huge and every topic has immense advancements and immense knowledge. So I think better to stick to targeted one, which will be helpful for our final exam also.
Definitely. Or otherwise, like if someone wants to read, it is open for all. Just for discussion part, we should focus on exam oriented reading.
Yeah, correct. I agree. I totally agree.
That is okay, ma'am. But our target is to face the exam. Then we will be not able to end and revise. Like we will be just discussing these topics and exam will be there.
If time permits, first we'll go through what we have to write in exam, and later on.
Yeah. Totally. I think targeted approach will be much better because these slides again we have to remove the slides, go through everything, and even what Dr. Avnit was suggesting was also good. I feel like even in Word format, if we write and like if we give in a group, it will be much better. In the end, we can just go through this that PDF or whatever Word format is there for that particular question.
People who have iPads, they can make notes on iPads. Otherwise, other people can make like PDFs of notes or OneNote कैसे भी करके questions का हर question का एक आंसर अगर हम लोग सोच के डाल दें तो जाएगा. सबके पास एक नोट्स का वो हो जाएगा ना, बैंक हो जाएगा कि मतलब questions के तो आंसर सबके पास है ही.
It will be better. Yes.
Actually, I have notes. I got it from somewhere. All systems and all. I'll share in the group. You can go through that, and if something need to be added, you can add on to that. It would be better, I think.
Yes, sure.
And what you are saying, like a question to answer, is fair enough. And if you want some extra knowledge, particularly related to topic, you can add extra slides at the end of the answer for that particular question only.
Yeah, correct.
True. But our first motto should be regarding exams only. At the end of the theory question, you can add whatever you want to add, 3 or 4 slides or 5 slides specifically.
Exactly, the field is so vast now. It is surgical oncology, like it is never ending. So if we become specific, it will be.
And whatever we are presenting here in the exam pattern, the question is he always tries to split into 3 to 4 parts, and whatever we write is very limited. Whatever we are reading is so vast that we cannot reproduce everything in the exam.
Yeah.
Selectively, we have to pick and write in the exam. So I think that would be better.
Definitely. System wise we can do, otherwise we can do year wise also. Like the most recent one we can discuss, give one question to 4-5 people every week.
You can separate all questions into system wise, and we can give them 2 to 3 candidates each system. 2 or
इसमें
3
question
candidates.
डाला नहीं। Someone has put the questionnaire on the group ना, we will follow it system wise. वो सिस्टम में अगर 3 लोग एक सिस्टम ले रहे हैं तो 3-4 लोग जो भी है, हर एक जन एक 2-2 क्वेश्चन लेके। Yeah. यू आर राइट, बट कैसा है, अगर सिस्टम वाइज गया ना तो एक टाइम पे सब क्वेश्चंस कवर करना इज वेरी डिफिकल्ट। एक सेशन में अपने मैक्सिमम 2 या 3 क्वेश्चंस ही होने वाले हैं।
And I want to say one more thing.